have to think that way, and you have to modify your anesthesia technique so that in order to give a block better. Okay, again the modification is you can just give a local infiltrations wherever you're working. Being spoken about it here. Unfortunately, because of the time constraints, I could not be displaying all the CBCT images here. Okay. Okay, 28-year-old female. What do you see? This is what the CBCT showed us. And also the initial stage of the ossification of the thyroid cartilage. Pterygoid plates, elongation, bilaterally, pterygohilar bar, and then the plexus of the mandibular nerve. This is one of the reasons why the patient says, no matter how many injections you give me, I still feel pain. Okay, this radiograph we already saw in one of the positional artifacts, right? There's an axial rotation of the patient. But what exactly is the variance in this patient? Yeah? Butt faces? Condyle? Okay, there's a steep sigmoid notch, okay. Very steep. This is okay, this is one of the variations. What else? This patient does not have a mandibular canal on the left side. She does not have a mandibular canal. She just has a small plexus on the right side, but when you see it on the left side, she does not have any canal. It's totally bone. It's totally bone. Now, how do you say? You might ask, if there is no innervation on inside the bone, how is it that the patient is still managing? This is because of the soft tissue innervations and also the innervations from the mylohyoid nerve. Okay, this is fairly simple. This is a radiograph which is commonly encountered in all clinical practices. I think we see this kind of radiograph time and again, every day, day in and day out. Fantastic, yes. This patient is of Eagle syndrome, bilateral, wherein you see the entire length of the stylomandibular ligament involving the styloid process getting ossified bilaterally. Okay, this patient gives a history of trauma to the face 1 week back, and he says he has pain behind the ear. Look at the styloids. Are they bilaterally symmetrical? Are they or they're not? They are? They are. There's asymmetry. What is the asymmetry? There's no asymmetry. They are symmetrical. Only thing is this styloid bone is fractured. See this? This is continuous. Okay? And here it's fractured. Okay, 25-year-old female, again with elongated condyles. Then what else? What else? Okay, nobody's interested. Okay, this is the answer. Now look at the OPG and tell me what. You see something bleak here? A small flower? You can see or no? Nobody can see? I think this is when you have to use the magnifying glasses to see something there. This is again an incidental finding. This patient had a compound odontoma, like a flower. She had 3 small tooth-like structures. Okay, this is again fairly simple. What exactly do you see? You see a tonsillolith here. You see a tonsillolith. Okay, but this is a syndromic patient. Okay, this is a syndromic patient. The striking feature in this patient when I saw this radiograph was this patient is missing the external acoustic meatus. There's no external acoustic meatus. Okay, now discovery consists of seeing what everybody sees and has seen and thinking what nobody has thought, right? Okay, this was one of my patients, 41-year-old. This was recently published in month of February. And then this was incidental discovery. Okay, this patient, what is the variance you see in this patient? The sinus is all normal, sir. Sinus is normal. The variation in this patient was, the patient has a coronoid foramen bilateral aspect. He has a foramen here, he has a foramen here on the coronoid aspect, and he has a big lateral foramen on the lateral aspect of the body of the mandible. And this, I printed the scans with a stereolithographic model of the same patient. I made it 3D print, size 1:1, life size, and these are the number of variations which I saw on this patient. And this is what made this article and study so interesting that they accepted it to be published in the official Journal of Clinical Anatomy, February. This patient had bilateral coronoid foramina, okay, and he had 3 foramina on the mastoid process, 5 foramina on the left side mastoid process, and then she had a foramina in the external gastric meatus. Look at the infraorbital foramina. Do they look normal to you? They are huge. And also a foramina on the frontal bone and also a temporal bone. This is the frontal view, the profile in the frontal view. See this? This is the infraorbital foramen. And then there was a bar here which is actually, we could not hold the strength, and then it was broken. And there are 3 different foramina, 1, 2, and 3. Okay, this was the article which was published. Again, this is the bonus slide. And this is again a 63-year-old female. No clinical signs and symptoms of anything. Patient is hale and hearty, everything. The only thing is, she says, no matter what kind of anesthesia you give, it doesn't work intraorally for her. She had inverted bilateral third molars, but the variation is in the coronoid. She has a big foramen on the coronoid process bilaterally. Okay, this is the bonus slide. This is the last slide and the bonus slide. Okay, I told you in the beginning, when the patient is positioned far ahead in the chin up, you sometimes tend to visualize even the thyroid cartilages, right? When you see the thyroid cartilages, this patient came to us. Incident, again, this is an incidental finding. If you look at it on the left side and the right side, okay, this is the right side, this is the left side, what do you see? See something, some big bony thing here? You see or no? Is it clear or no? Bilateral. There's an artificial joint which is created here. This joint is due to the ossification of the superior horn of the thyroid cartilage with the tritichial cartilage. This tritichial cartilage ossifies and then it fused with the hyoid bone, limiting the patient's movement, neck movements. This is under publication, inshallah. Okay, thank you so much. I think this is about it. And then we'll take a short break for around 10 minutes, and then after that we'll get back for a final presentation of, I operated a recent case of an anatomical variance wherein the patient had an elongated pterygoid hamulus, and then I surgically excised that pterygoid hamulus, and then the patient is doing good now. I just have a small 10-minute case presentation regarding that. I think we'll finish the tea and then we'll assemble back for that presentation, and then we are good to go.
That was one of the most fantastic presentations on OPG. I feel like I'm in a no man's land, and I have to go with the odyssey of starting on my reading OPGs again. Long journey in reading OPGs. Okay.
It's not rocket science. It's just, you just have to put your mind to it.
One good thing what I could read from your OPGs is very bad root canals here.
Yeah. See, don't blame it on me. Don't blame it on me. And that's how the patients come to me.
And second thing is, Shiraz would definitely agree with me. They're all metal pores there. There's no fiber pores.
I think this is rampant in the region where I practice. I think that's what they maybe because it's reading a very small, I don't know how it is. Because the doctors the patients which I see the information, they are
so he basically uses the references. Very few of these eventually lost the
unfortunately, we don't have people like Shiraz.
the only thing I could focus.
Yeah, I forgot to mention it.
Break for tea. We'll come back after 10 minutes.
Yeah, Dr. Shiraz, it was very much informative, nice presentation from you. I have a question not related with the presentation. First question is about cleaning and shaping of the root canal. There's some, maybe what I know, maybe a newer thing which has come out. There is apical torque control in the handpiece, in the endomotor handpiece. Apical torque control. So how I want to know how far it is means it is clinically related, or it is more of a operator related. If you are an experienced person, you may not require those features in the handpiece, or it is really essential.
Just on that, no? Can I have Dr. Iftekhar, please?
Hello. Yeah, your question is torque control motors are really required to do endo, or without torque control we can use. That's the apical torque control. What's the difference in apical torque control and normal torque control motors? Can you please elaborate? Morita, huh? I am not aware of that really, actually. Sir, apical torque control, we need to add.
It's the same thing, I think.
I am not aware of it. It's a new, I think, see, day to day we get a lot of gadgets which gets marketed and I think we should be little wise to wait and watch whether it stands the test of market and then probably invest into it. Maybe down the line we will see if there is any advantage. Probably we'll do some studies and see how good, if there is any less fracture, less separation of instruments in apical torque control. We need to see if it is any new thing. It's always wise to wait and watch and then invest in the material.
Is it that you're trying to say that generally when we do the preparation, we are concentrating more on the apical third? So probably they've used that word, that apical torque control.
No, sir, no. Actually, it's not about that. What I came to know, there's if you know, there's new endo files is there. So they are from Oricam. So the same company is having eConnect handpiece. That's for endodontic treatment, and they are having eConnect Pro handpiece. Now they have launched a new one, that is eConnect S. That is something similar with the Morita's new version. So in that they have given another added feature is apical torque control. And what little bit I come to know that that is basically something which is good when you have a curved canal where apex, where apical 1 millimeter or 2 millimeter, the canal is curved too much, and the other files, it tends to automatically adapt with the canals. Means it tends to have a proper torque and a proper speed automatically. You don't have to change operator. That's what thing is that.
Essentially, we don't usually change the torque. We can keep the see. Basically, torque means it is the resistance lateral for the lateral forces. And torque control helps in when the file is passing through a very narrow curvature or a very narrow space. It helps in it prevents in binding. Okay.
Yes.
So what you said is if it is only in the apical region where the torque control is, and what about the coronal region? If maybe to prevent the taper lock, where if you are using a large instrument in a very narrow canal, or if it is a very curved canal, then to prevent the taper lock, maybe they are using some technology which I think we need to still explore into it.
Yeah, actually what I wanted to know, because even I'm not able to get the complete information, only this much I got it. But the thing is that what was the confusion is whether this is really helpful, means the technology, or whether an experienced endodontist who is having this kind of means with his experience, he can able to handle these things and all very efficiently in those cases.
See, ultimately, if you have a good glide path and if you have enlarged your apical region to number 20, probably you can you don't need all these gadgets. You can do without a torque control handpiece also. I have two handpieces. One is with torque control, without, and another one is without torque control. And most of the cases I do without torque control. So probably your handpiece should be the extension of your fingers. So you can feel it when the file is getting stuck. So
Okay. And
hope I answered the question.
Yeah. Okay. So next is related to your topic, that is post-endo. You told about different options of the restorations, especially. This monoblock concept.
Yeah.
So if I have to take one thing as being a clinician or private practitioner, what I should take it for the post coronal restorations, which can be used most commonly or most widely with least failures.
Which post system?
I mean post system, which can be used most widely and which least failure, good prognosis.
See, my friend, there is no magic formula for, there is no one tool for everything. See, each case is different, and each tooth or each root canal is different. Based on even the occlusal forces, we need to take a call, and based on, that's why I went in elaborate with how to select a post and what are the indications and what are the criterias we take. And depending on each canal and each case, we need to, posts will fit into each category. If there is not much of tooth structure, then your cast post will be very good. If there is good enough of good amount of ferrule, then you can use a fiber post. And see to that the luting agent which you use should be dual cured. Based on the discussions with the people, I just found out that dual cure cements are a necessity when you are cementing a fiber post. If you are using a metal post, even phosphate cement will do, even zinc phosphate will do. But for fiber post, luting agent, you have to use a dual cure.
Okay, thank you very much.
You want to add something, sir?
Any more questions regarding the pre-endo, post-endo radiographs, IOPS? I think the most active participant is my doppelganger, Dr. Nadeem. Thanks for being so active here.
This question is to Dr. Nyer. It's really a fantastic, you brought it, this retractor. And I think those who have done this impactions, they know it very well. How difficult to use those kind of retractors. This is all-in-one solution, I believe. Only I just hold your this thing, retractor. It's made of stainless steel, I believe.
It's made of 317 medical grade steel.
Yeah. So just a kind of inquisitive inquiry.
Okay.
Could it not have been done with some other material which would have been slightly much more flexible? Maybe a kind of a fiber which can be autoclave?
The metal which we used to manufacture this device is flexible enough to take the necessary amount of forces. But then too much of flexibility will distort the instrument, the design of the instrument, and also it will distort the entire concept.
Okay. Thank you.
Thank you so much. Anything else? Or regarding anything. You have a question? Okay, thank you.
I have a question to